So I'd like to offer a welcome on behalf of the Royal Society of Canada and the COVID-19 Immunity Task Force. So as Canada's National Academy, the Royal Society recognizes Canada's leading intellectuals, scholars, researchers, and artists, and mobilizes them in open discussion and debate to advance knowledge, encourage integrated interdisciplinary understandings, and address issues that are critical to Canada and Canadians. The COVID-19 Immunity Task Force was created by the Government of Canada and leads a Canada-wide effort to help determine the extent of SARS-CoV-2 infection in Canada, understand the nature of immunity following infection, develop improved antibody testing methods, and help monitor the effectiveness and safety of vaccines as they are rolled out across Canada. The RSC and the COVID-19 Immunity Task Force are hosting this event, and their offices are located on the traditional unceded territory of the Algonquin Nation. From coast to coast to coast, we are grateful to acknowledge the ancestral and unceded territory of the Inuit, First Nations, and Métis peoples, and recognize the dozens of languages and cultures Indigenous peoples have brought that enrich what many call Turtle Island. This event is offered with live interpretation into French. Cet événement est offert avec interprétation en direct en français. Pour accéder au fil en français, cliquez sur le globe en bas de votre écran et sélectionnez Français. This event is being recorded and will be posted online in English and French on both the RSC website and on the CITF website following. So if you miss anything, don't get nervous that your notes are going to be incomplete. Today's event explores themes of the RSC policy briefing entitled Children in Schools During COVID-19 and Beyond, Engagement and Connection Through Opportunity, which assesses the impact of COVID-19 on children and the school system. And you can, of course, access that in full on their website. My name is Shannon Proudfoot. I'm the Ottawa Bureau Chief for Maclean's. I'm located in Ottawa, and I'm going to introduce our panelists and participants today. First is Dr. Tracy Vaillancourt, Tier 1 Canada Research Chair in School-Based Mental Health and Violence Prevention, and a Professor of Counseling Psychology in the Faculty of Education at the University of Ottawa. Next, we have Dr. Carolyn Quash-Tan, Canada Research Chair in Infection Prevention, Professor in the Departments of Microbiology, Infectious Diseases, and Immunology, and of Pediatrics at the Université de Montréal, CHU Saint-Justine, co-chair of the Vaccine Surveillance Reference Group, and COVID-19 Immunity Task Force Leadership Group member. We have Dr. Jim Kellner, Professor, Department of Pediatrics, Community Health Sciences and Microbiology, Immunology and Infectious Diseases at the Cummings School of Medicine, University of Calgary, and Alberta Health Services, Chair of the COVID-19 Immunity Task Force's Pediatrics Network, and a CITF Leadership Group member. And we have Dr. Curtis Brown, Superintendent at South Slave Divisional Educational Council and President of the Canadian Association of School System Administrators. So I'll give you a quick rundown of how we're going to do things today. First, we're going to hear from Dr. Vaillancourt as the lead author of the RSC report, and then I'll begin a discussion with each of our panelists. After this, we'll open it up to questions from the audience. So if you have questions for these experts, please submit them via the Q&A feature at the bottom of your screen, and we will get through as many of them as we can today. Should you wish to join the conversation online or to learn more about RSC events, please follow them on Twitter at RSC The Academies, and that handle has also been included in these slides, so it's easy to find. Now I'm going to let Dr. Vaillancourt get us started with a summary of some of the findings of the RSC report.
Thank you for the great introductions. So I'm going to just present our key findings, and I really want to highlight that our report is extensive and exhaustive. So obviously I'm not going to speak for the next 5 hours on this topic. I'm just going to give you a summary of what we think are the key highlights, but I really encourage you all to go to the report because what I'm going to speak to you briefly about will not do the report justice. So in terms of core recommendations, we really believe that schools must be the first to open and the last to close. And unfortunately, far too many children in Canada were subjected to very long school closures. But if we want to keep schools open, especially as we enter this fourth wave with the Delta variant, we need to really prioritize educators and students in our vaccine rollout plans. And historically, that has not been the case. So if we're to need a another injection, a booster, then I think that educators need to be at the front of the line, just like healthcare practitioners. We also need to fund infection prevention and control measures. And by funding that, I don't think we could just leave it up to provinces. I think the federal government needs to step in and provide funding to schools across our country to make sure that they're keeping educators and students safe. We also need to address educational gaps. Because of the school closures and because of all the disruptions in learning, there are notable gaps in learning. And unfortunately, the cost borne to students who are already vulnerable to begin with, so those who were disadvantaged before the pandemic, they're the ones who have been disproportionately disadvantaged by the pandemic. Intervention programs are needed for students, these students in particular who have been impacted by interrupted or unfinished schooling. I think we tend to think about the fact that kids were out of school, we went online, we managed them quite well, and everybody's doing okay. But our report does not suggest that that is indeed the case. We need to take steps to reduce inequity. And it was pretty striking how this is such a core issue. And we believe that schools are the place where we can actually address a lot of the inequities that exist in Canada. And we believe that schools should never be the place that they get magnified. So this is something that needs to be addressed. And again, if we talk about the cost has been borne disproportionately to those who are vulnerable before the pandemic, this is quite problematic. We need to improve internet and digital access. And again, we go back to who has been able to be educated during the pandemic. It hasn't been kids in rural areas, and Dr. Brown could speak to this a little bit more. It hasn't been children who've lived on reserve. It hasn't been children who don't have access to devices or high-speed internet. Education is a human right, and it's one that's currently not being met by far too many Canadian children because they cannot access the curriculum from home. We need to create a national children's mental health strategy, and we've been arguing this for a very long time. Before the pandemic, before the pandemic, 1 in 5 children had mental health problems. And this has been even more pronounced since the pandemic. In order to ameliorate their mental health, we need to focus on social emotional learning and development. And importantly, we need to track our progress. We don't have enough longitudinal population-based data in Canada. And this has been a huge problem with us being able to respond to the pandemic, to know where we should put our emphasis and the like. And I'll say this, that we measure what we value and we value what we measure. So if we are to be prepared in the future, we better get going on measuring things now. We need to support teaching as essential work, and this hasn't been the case during the pandemic. It is shocking how poorly they've been treated during the pandemic. It's really brought out the worst of our behavior. And I think that we need to go back to understanding that these are professionals. They're well regarded by me and others, who, but maybe not by as many as they should be. So highly qualified individuals, they're professionals, and they deserve the support. And they're also essential to our well-being, to our economy, and the like. We need to improve teachers' expertise moving forward in the area of digital pedagogy in our teacher prep programs. And the reason being is that when the pandemic hit, we noticed that we weren't as well equipped in this area of expertise. And it would be really good if we could be prepared, because this is actually the way of future learning. And finally, we need to prioritize recess and other forms of breaks. So what happens during the pandemic is that we prioritize reading, writing, and arithmetic at the cost of children's relationships, which I think is the first R of education. And relationships happen when kids have downtime. So we really need to be thinking about their downtime. So those are our core recommendations. Obviously, the list is not exhaustive. The report, I think, is in a lot of ways. And again, I encourage you to go back to reading it. Thank you.
Dr. Quash, I have several questions for you to get us going next. Are many children and adolescents getting COVID? Are they getting it at school? And what do we know about whether they're having bad cases or severe consequences?
Yeah, thank you for the question. I think you have to just realize what the context that I'm in. So I'm in Quebec, where we had in-person teaching all year round last year, even through the second and third waves, and where we were able to track COVID cases. So if I start in school, what we saw is that, yes, we did have cases, and we still do have some in the fourth wave. Most of the outbreaks, though, were of small numbers, so 2 to 5 cases maximum per cluster. When we tracked down and drilled down those cases, we saw that most of them, so 3/4, were actually caught from home or the community. The transmission in school wasn't that important, and that also relates to teachers, so that teachers did not get infected through school. Oftentimes it was caught elsewhere, and then sometimes it was a source of infection within school. In terms of number of cases, when we look, let's say, at the either wave where the Alpha variant or the Delta variant were at play, so last spring and this fall, we do see an increased number of cases in children. So mainly those in elementary schools where a vaccination is not yet available. But at the same time, looking at what happens in our hospitals, whether it is in Dr. Kellner's hospital in Calgary or mine here in Montreal, we are not seeing an increased number of admissions. In fact, and maybe Jim might comment on this later, but what we see here is that we're having mainly admissions of young infants, so those less than a month of age, who catch this infection from their parents who are not vaccinated, or who decided to delay the vaccination until after pregnancy. And that's what we're seeing. But otherwise, I mean, the school-age children are not being seen, or barely. We're having between 0 and 3 to 4 cases per day of COVID admissions. What is currently really putting a toll on our hospital is all the other viral infections. So whether it is RSV, enterorhinoviruses, so all those other respiratory infections that usually come up in the winter, that just decided to change their season and are now all over the place. And so parents are coming to the emergency rooms because their children are having fever, but it's not because of COVID. And then another complication that you've probably heard about is the MIS-C, or PIMS, which is this multi-inflammatory syndrome in children. Interestingly, we seem to have more of those last year, and so far this fall we haven't had many, even though our fourth wave started in mid-August here in Quebec. Same in France, where they've done quite a vast study of their cases. Most of their cases, and it's the same for us, are happening in those between the age of 5 and 9 years of age. And it's often associated with a heart inflammation, so myocarditis. And so, and oftentimes, I mean, even though they seem quite sick when they come in, and some will require ICU admissions, in the long run, this does not seem to have any long-term sequelae, which is actually quite reassuring. So I think, you know, if I summarize the situation in children, this virus, for some reason, is not causing any major disruption in their lives. They might get a cold. In fact, when we're looking at seroprevalence, so their antibody response, we are seeing approximately 10% of children who are now positive, or in fact in May, who were positive for antibodies. And I would say 3/4 of them have barely had any symptoms, which means that they are getting infected, but they're not really sick. And so again, children are not particularly sick with this virus. I think what we are trying to limit is the transmission of their infection to older or adults that could end up being hospitalized if they are not vaccinated in particular. But otherwise, I mean, the in-school teaching was actually quite favorable last year here. And so we're continuing the same way here. And there's only a handful of conditions for which children are not allowed to go to school. And they're really similar to those that could not go to school in a regular influenza season. So let's say you just got a bone marrow transplant or solid organ transplant, but otherwise, most of the other children are just going to school. Thank you.
It's very interesting. Thank you. Dr. Kellner, I have a few questions for you next. Are we likely to see more cases in children in the coming weeks and months like we've seen in the United States? And what can you tell us about when vaccines will be available for children under the age of 12 and their safety?
Sure, thank you. So I'll talk about cases first, and might have to remind me about the vaccines. So, and just to sort of complement and extend on what Dr. Quash said, you know, we are across the country in Canada in the fourth wave right now, the Delta wave, much more transmissible virus. And the Delta wave is playing out quite differently, you know, across Canada. If you look overall at active cases of COVID in Canada, about 1 in 850 Canadians has COVID-19 infection today. In my own province in Alberta, we have almost 4 times that, about just over 1 in 200 Albertans have COVID-19 today. And so the larger the number of persons who have COVID in a community, the larger the number of children will be. And it's part of it's related to testing, and then part of it's related to the sort of clinical features. As Dr. Quash said, the cases, a lot of them are without any symptoms. Probably about a third of diagnosed cases in children are without symptoms, and about 2/3 have mild symptoms. So just in the context in Canada, we know that children are only about 9 times less likely to be admitted to hospital or end up in an intensive care unit than adults are, and they're far more unlikely to die from COVID. And so that's what we know is good. If a child ends up in hospital with COVID because of COVID, though, it tends to be a significant illness. And about, you know, and there's newly published data in Canada showing that across the country, about 1/5 of children who are admitted, 20% are actually admitted to an intensive care unit. Fortunately, again, deaths are rare. So the concern in the United States is that there's been with the Delta wave there's been this very large increase in the number of children presenting to emergency departments, ending up in hospital and end up in intensive care units, and to some extent dying from COVID. A way you can look at this, and it's been done in the US, is to look and say in August, to say, how does the likelihood that a child is going to end up in hospital and ICU and maybe die from COVID correlate with vaccination rates and public health measures in the community? And, you know, we all know that in the US, it's highly variable, just as it is across the regions of Canada, what vaccine uptake is. So if you look in the US at the areas with the lowest amount of vaccine uptake, and this gets into small numbers, like under 50% of the population over 12 being vaccinated. So that'd be like under 40% of the whole population being vaccinated. In states like that, and in states like that where there are no public health measures, essentially no masking, and there's laws against being able to wear masks and do anything at all in the schools, there you're seeing a huge jump, a multifold jump, sort of 8 to 10 times jump in the number of children presenting to emergency departments and being admitted to hospital and ending up in intensive care units. The bottom line is, I don't think we're going to get there in Canada, because even in our worst provinces, which are my own province of Alberta and Saskatchewan, our levels of immunization, as low as they are compared to the Canadian average, are much higher than even the best quartile in the United States. First, and second, in most provinces and territories, there are still some, you know, ongoing public health measures to try to reduce transmission in the community. And again, my own province of Alberta, there was this moving away from really any public health measures in the summer, and we're paying the price for that now because our vaccination rate wasn't high enough, and we moved too soon to eliminate public health measures, and so that combination led to a big jump in cases. And so we're seeing a lot more than the rest of the country right now, except for Saskatchewan and the Northwest Territories, but nothing near what it is in the US. So it's a very long answer to your question, which is that I don't think we're going to see the kind of jump that they've seen in the United States in some places. And while we're having more COVID-19 in children here in Alberta than in Quebec, for sure, as Dr. Quash said, it's still a small number of children who are ending up in hospital. But the ones who are ending up in hospital, you know, there are, some of those kids are sick for sure. And so I think we're going to, you know, just not see anything close to what they've seen in the United States.
That's certainly reassuring. Can you tell us about when we might expect vaccines here for kids under 12 and the safety of them?
Right. And so the vaccines that have been looked at for children in Canada and considered of the vaccines that are available to us are the mRNA vaccines, so the Pfizer vaccine and the Moderna vaccine. And both companies are conducting clinical trials in age groups on children under the age of 12. I think everybody will know that the vaccines are approved and recommended for use for every Canadian age 12 and above right now. The vaccines are being tested in younger children, and a couple things to say about that. First, they're being tested in age group blocks. So the first age group block is from either 5 or 6 years of age to 11 years of age, and then a younger block and a younger block after that. Pfizer, as most people know, released some top-line results on their study of 5 to 11-year-olds a few weeks ago. And last week, they submitted that information to the FDA in the United States. And I heard over the weekend that they also submitted to Health Canada that information. Now, we don't really know all the details yet because all that's been released is some top-line information suggesting that in these studies, which are smaller studies, so-called bridging studies, that the immune response looks similar to older adolescents and young adults, and that the safety profile is similar, but we don't have any details on that yet. And in a bridging study, you'll know whether or not the vaccine is likely to prevent disease if you have enough information suggesting that the immune response is the same, and then also that the safety looks the same. So people are wondering how long is that going to take and where we're going to be at. And I just want to say that I think that the situation is going to be a little bit different for younger children, but because first of all, the evaluation of the vaccines by the regulatory agencies are being done on the basis of this immune response and safety with relatively small numbers. And so there simply won't be enough information to be able to extrapolate and say, well, what about the likelihood of very, very rare adverse events like the myocarditis that people are worried about with young adults, especially males. And we simply won't have all that information in hand when decisions have to be made about how to use the vaccines. Nevertheless, we can expect that the process will be careful and comprehensive, but it'll be rapid. And with previous submissions to the regulatory agencies, Health Canada here, when it came to looking at the 12 to 16 or 17-year-old age groups for the vaccines, that evaluation review was done in just a few weeks. And so I don't think we'll be waiting very long till we have at least some word from the regulatory agencies. So lots of people are keen to hear where we're going on this, and there's more to come. We simply don't have all the information yet.
Thanks very much for that. Dr. Brown, I have a question for you as well. You're really well placed to sort of tell us how all of the things our panelists have been talking about so far are playing out on the ground. So can you tell us what are you noticing in schools that relates to this research so far? What are you seeing? What are you hearing from colleagues?
Well, I think everyone knows in Canada, all provincial and territorial schools were closed for extended periods at some point during the pandemic. But now I think in every province and territories, keeping schools open is definitely a priority right across Canada. For the NWT, where I live and work, our schools were closed for the last 3 months of the 2019-20 school year when the pandemic first arrived. But then they opened up again, similar to what was Dr. Quash shared about Quebec. And stayed open for most of last year. Almost all NWT schools remained open for the entire 2020-21 school year. Unfortunately, some NWT schools have had to close for several weeks here, due in part to some relaxing of the travel and isolation restrictions, but coinciding as well with the arrival of the more contagious Delta variant. And as everyone knows as well, educators, students, and families had to pivot on a dime to fully remote learning for children and youth who couldn't attend school in person. Parents and other caregivers shouldered the weight of supporting their children's learning. And despite those valiant efforts, for most students, those variations in delivery methods that were developed urgently at a time of crisis were far from ideal, resulting in many students simply disengaging. And particularly, as Dr. Vaillancourt indicated, particularly the most vulnerable children and youth who were already dealing with numerous challenges. So those closures, they thwarted children's fundamental need to belong, resulting in greater social isolation and loneliness. Children and youth were not only isolated from their peers and their educators, but they also experienced lengthy separations from extended family, community networks, coaches, teammates, counselors, and so on. And then when students returned to blended learning, student engagement and behavior were a challenge, partly a result of the lengthy absence and partly because of the new pandemic rules that were restricting student movement and requiring masking as well. And the pandemic has highlighted and magnified some pre-existing inequities. For example, those who were already at risk of dropping out, who need direct instruction and more supports in order to be successful, are less likely to get those supports while schools are closed, of course, or even in a blended learning situation. And too many children and youth simply disengaged with again, the influence deeper for those already at risk before COVID-19 was declared a pandemic. But perhaps the most notable inequity that quickly came to light during the school closures was the lack of internet access and digital devices in most homes. Access to online learning is far from equitable, as far too many Canadian families lack access to reliable, high-speed digital technologies. And this isn't just in the rural centers either. Winnipeg School Division reported last year that 40% of their students did not have a computer at home. And that's a major city with a higher percentage of tech. There are a much higher percentage of tech-deprived homes in rural communities. Less than 50% of Canadian households had internet when the pandemic started. Before the pandemic, only 12.6% of Canadian households had broadband or high-speed internet. So there are also many areas in the country where internet access is just incredibly costly, including Indigenous communities and those in northern regions. For example, in Nunavut, over 50% of the households with internet have download speeds of less than 5 megabytes per second, which is insufficient bandwidth and reliability to show an educational video or to sustain a video conference like the one we're on right now. So this digital divide between urban and rural communities is one way in which inequities have been and continue to be sustained through the pandemic. And schools and school boards, governments tried desperately to find ways to level the playing field by loaning internet-enabled devices, digital devices to families. Here in the territories, we had Chromebooks and turbo sticks that we were handing out to families, only to find out in our small outlying communities that the connection speed, the bandwidth was so unreliable. We're connected by a satellite link. They were so unreliable that they simply didn't work. We had hotspots where we just turned routers around in our schools and invited kids to come to school grounds when they could and access the router in the school. Again, those efforts are laudable, but certainly didn't address the needs of all kids. Two other things I wanted to quickly mention. I think most everyone's probably already aware. The negative reach of the pandemic also extended beyond the primary purpose of schools. For example, school closures impacted food security of children and youth. All of our schools in the NWT provide breakfast, snack, and lunch programs, and those services came to an abrupt stop during the closure. The school closures also impacted the detection and reporting of child maltreatment and neglect. Our child welfare partners told us that at-risk families in poverty or suffering with mental health and addiction issues were confined to their homes just like everyone else, but now they didn't have the school day for daily routine, structure, and respite, and child neglect and abuse increased. And at the same time, there were fewer eyes on kids on a daily basis, to notice and follow up on any welfare concerns. So we were told that when things finally did come to the attention of Child and Family Services, the cases were more serious. And we didn't realize, quite honestly, we didn't realize how important a component of the child welfare system our schools were and are until our schools closed. I'll just close here on two items. So one of the best ways to mitigate threats to well-being, education, food security, and safety of children and youth is to aim to keep schools open whenever and wherever it's safe to do so. As I said, that is a priority right across Canada, I think, right now. The other thing I wanted to touch on, and Dr. Vaillancourt touched on this as well, the pandemic has been challenging for teachers, support staff, and principals who have been faced with having to quickly adapt their learning environments, being vigilant around ever-changing public health directives, worrying about their own health and safety, all while trying to keep children and youth engaged and motivated. And that's been no small feat, and one that must be recognized and valued as well. Thank you, Shannon.
Thanks very much for that. We're going to go into the Q&A portion of our session now. So I would invite, we already have a few questions coming in, but anyone else who has questions burning a hole in your pocket, please go ahead and submit them. I'm going to get us started, and then I have a few others that I've pulled from the chat, but please go ahead with them, and we will ask our experts. So my question to start us off, and I'd invite any of you who want to weigh in here to do so. I noticed many of the recommendations in the RSC report are quite broad, and I think they match what a lot of parents and citizens would think should be our priorities. You know, things like the safe reopening of schools, keeping schools open because of the enormous losses if we don't, you know, proper funding for infection prevention, things like that. But I'm wondering if any of you can speak to what specific elements or measures or policies on the ground would actually support those goals. Like, what do we need to see happening in reality in order to kind of try to meet those things that we all would probably agree are important? Please, anyone chime in as you see fit.
I'll chime in first, just because we wrote the report and Curtis was one of the co-authors, so it was really nice to hear his comments. I think it's a fair question. But within each chapter, we have very specific recommendations. So it may seem broad from the executive summary, but in fact, it's not broad. There's actually a blueprint of what can be done and how it should be done. So I can appreciate your point, but I just wanted to add that. And I'll give you one example of a policy point. So we argue that we need a children's commissioner. We say we value children in Canada, and yet who's advocating for children? And it's interesting because we just had a federal election and children were not at the front of anybody's platform. And that's a huge miss. They have suffered tremendously during this pandemic. They're always an afterthought. And so we need somebody to be advocating for them, somebody who would have the ear of our Prime Minister, making sure that the agendas always reflect children's needs. So that would be one policy recommendation, and that is specifically advocated for in our report.
That's a great example, thanks. Is there anything anyone else wants to chime in with there, or should I go ahead with the next question?
I can speak, Shannon. You know, the specific bottom line goals, I believe, are to keep everyone healthy and safe, one, and two, to continue to provide the best education possible. So with that in mind, you know, pragmatic steps include, I think, encouraging everyone to get vaccinated and to stay the course with the virus mitigation measures, symptom screening, masking, distancing, enhanced cleaning, at least until we get our young ones vaccinated. Our territory here has just announced vaccination requirements for health workers and educators working with the vulnerable sector. So that's a tangible, pragmatic step in terms of ensuring everyone's staying healthy and safe. In terms of education, the best education possible, I keep coming back to, in my own mind, what I need to keep reminding myself and the staff that I work with, the principals and staff that I work with, is that relationships and communications come first. Every student needs to know that the teacher likes them, believes in them. Teachers need to be explicit about that with each student. We need to encourage everyone to stay positive as we can. I'm so proud of our principals and our teachers and our parents for having done that very, very well. I think despite everything that we're dealing with, everyone's stressed and frustrated. Many are experiencing loss, and to apologize if we've gone overboard ourselves as well in interactions with others. Of course, universal internet connectivity may be a long way away. Even the Canadian School Boards Association and the Canadian Association of School System Administrators wrote a joint letter to the federal government and have yet to receive a response. We'll keep prodding, but we need to stay positive and work the best we can with the resources we have, and we owe that. I don't know if people are aware, but tomorrow it happens to be World Teacher Day. Teacher Appreciation Day. Canada is one of about 100 countries that recognize teachers on October 5th each year. And so I encourage every one of us to reach out to and thank a teacher who made a difference in the past or who is making a difference now. Virtual Hug a Principal. I think they've had it the toughest in education. Perhaps this year more than ever, our good educators need to know they're appreciated, and I sincerely hope that they get all the appreciation they deserve tomorrow and every day. By the way, on a conference call with other superintendents across Canada, somebody said this, I don't know who it was, but I thought it was a perfect mantra. The mantra was stay positive, test negative. Stay positive, test negative. I like that. It's how we move forward most productively.
Thank you. Now, we had this question come in from more than one person, and this is a hot topic these days. What about rapid testing? Is rapid testing a viable option to help keep schools continuous, to ensure health and safety? Someone specifically who lives in BC wants to know if it'll be coming for their province. I'm sure all kinds of people in different parts of the country have that question. So this might be questions for Dr. Kellner and Dr. Quash, but anyone who wants to take that, what about rapid testing? What's the place of that in this?
So I can get started. We did a pilot study last year with the use of rapid tests in 2 schools in Montreal, one in a higher income neighborhood and another one in a multicultural setting. And so what we saw is that using that test randomly on asymptomatic kids or teachers was actually not quite helpful, because it took so many tests day in and day out to actually find one, even though the prevalence in the community was 5 to 7% of test positivity. But what was quite interesting is that when you actually use them on children or teachers that were symptomatic, the sensitivity of the test was approximately 80%, which means that you can miss 1 or 2 cases, but that most of the cases that have a high enough viral load that could then lead to outbreaks were detected. And what was good with it is that it was detected rapidly, so that within 15 minutes, public health was notified, and so they could act on the rest of the family, make sure that people were isolated. But what is different this year on top of it is that because, as I said before, we're having so many other respiratory viruses, what we want is actually for kids to be able to go to school. So if they come into school one morning and they start to have a scratchy throat and a little bit of a cough, and you do the rapid test and it's negative, then at least you could leave them in school for the day, knowing that worst case scenario, it's COVID, but with a low enough viral load that it should not be transmitted. And then, at the end of the day, you can deal with the rest of the tests. But as a parent, you can at least know that when you drop your child off in daycare or in school, if something happens during the day, you're able to finish your day. Because if I look at my coworkers, because my children are too old, they're able to deal with themselves on their own. But my nurses around me here are being called in like every other day almost to come and pick up their child. And so, nobody's able to work, nobody's able to do anything. And that poor child is just miserable at home because all they want is to go back to school or daycare and be able to interact with others. So I think that's where the rapid test actually has a role to play. And so in the province of Quebec, that's how it's been implemented since the school entry in September, so that it's been deployed in all schools, not daycares yet, but in all elementary schools, or in spots where vaccination rates are not high enough. But so, you know, people have been trained in school, and they're not healthcare workers, but some people have been trained in various schools to be able to do that test. And so far it's been helping out a little bit, which, you know, it's really a first screening to make sure that if there is a COVID case, you're able to, you know, identify quickly and send that child home. But in, you know, the opposite is that if it's negative, at least kids can stay in school. Thanks.
Yeah, I could just add a little bit to what Dr. Quash said, that I think that even though, as she described so well, the testing isn't perfect, it is a good way of, and a good and practical way of sort of sorting and categorizing where children, as well as others and adults and teachers, are if they have some symptoms. And and what the experience in Quebec was last year has also been shown in other settings, and a big value. Like there's a big study from the UK that looked at this, and the main finding was that what it did, even though it didn't perfectly categorize every single person as to whether they have COVID or not, it helped dramatically minimize school disruptions. Children staying at home unnecessarily, whole classes staying away, schools being closed, that kind of thing, and just trying to minimize those disruptions. And so that's where you can see there's a value to it. And will this come in other provinces and territories? You know, I know it's being considered in a variety of other provinces for sure. Here in Alberta, that rapid test approach is being used as an alternative for folks who have chosen not to declare their vaccination status. So at the university next door to me, the University of Calgary, all faculty, staff, and students have had to declare if they're vaccinated or not, and extraordinarily high rates of vaccination. That's good. Handful of people have chosen the route of doing rapid testing, regardless of whether they have symptoms, twice a week. And that's another approach to the rapid testing, is not just with symptoms, but doing when you're asymptomatic. Comes back to the point that the testing isn't perfect. And so I think that this is a practical thing that can help keep schools open. But in general, we have to accept that it's not completely perfect at categorizing, does a child or an adult have COVID or not, but it probably is getting it right almost all the time and good enough to help keep the schools open.
It sounds like one of the enduring, you know, kind of tensions of the pandemic has been the tension between the perfect and the good, and trying to balance those things. I have another question now. I have a feeling this might be a good fit for Dr. Vaillancourt. Someone asked, in Ontario, schools were closed for an incredible amount of time over the last 2 years. Now that students are back, there's still a strong reluctance to allow extracurricular activities, things like sports, mixing cohorts outdoors. Given the importance of these activities for mental health and physical health and learning, how could we safely enable those things to happen?
It's a fantastic question, and it's one that I've been advocating for the past year. And I'm a soccer coach, so I'm intimately familiar with what's happening in terms of extracurriculars. And in Ontario, as one example, when we closed schools, we shut down all of their access to extracurriculars, including sports. And that had a devastating impact on a lot of kids. So they were isolated from their friends at school, and then we isolated them from their teammates, their girl guy group, and the like. And what I think happened, and I'd be curious to hear from other panelists if they agree with this, because this is just my hypothesis. We were so unprepared for this pandemic, and you would think we would have been better prepared, but we really were not prepared. And because we were so unprepared, we panicked. And in our panic, we went all the way to the end, right? Like where we had to shut down everything and we had to protect everybody from the virus. And it makes sense because there were so many unknowns. But we still decision makers who are caught in this moral panic. And it's causing harm to kids. The evidence from what I've read on transmission in sports is very low. And especially if it's a sport that's played outdoors. And so I think we need to be looking to the evidence and making decisions. Instead of these, we've had these approaches where there's no room for any interpretation in the middle. It's all or none. And I don't know how helpful that has been. We have enough evidence, I think, now to support that kids should be in schools and they should be doing extracurricular activities, unless, of course, there was an outbreak. If there's an outbreak in a basketball team, I'm not saying we should still persist in sending them to their practice. That makes no sense. So common sense should prevail on that. But in general, I don't like this blanket approach where, we say everybody is going to be removed from their extracurriculars and from school.
Now, someone else has a question about vaccines, the testing of vaccines for kids. Someone's asked, what are the sample sizes of studies on mRNA vaccines for children? And they're asking if someone could speak more about possible side effects in young males.
Sure, I can start with that. First about side effects, and especially young males, the main side effect that people are concerned about is this very rare occurrence of myocarditis with or without pericarditis. So those terms refer to an inflammation of the heart muscle, myocarditis, and then the lining of the heart, pericarditis. And they're often seen together. What we know about myocarditis and pericarditis in general in children is that it's a condition that's almost always triggered by a viral infection, and that it typically occurs, most typically occurs in newborns who have contracted one form or another of a viral infection, most commonly one of the enteroviruses, or in adolescents and young adults. And in addition, what we see in children normally with myocarditis, pericarditis, is that there's a real male predominance. And so, so that's the background of it, is that infants and adolescents and a male predominance. And it can be severe and life-threatening. What's become apparent with delivery of especially the mRNA vaccines, it's really not something that's been seen with any of the other vaccines, in particular in Canada, the viral vector vaccines. But with the mRNA vaccines, it seems that there's a very rare occurrence. By very rare, it's just a number, but we think of something that's very rare as being less than 1 in 10,000. And what the actual instance is of the myocarditis, pericarditis, is still being worked out in a variety of settings, where, including Canada, where these things are being looked for carefully and trying to determine. But it seems like the range of numbers, depending on the age group, depending on the study, depending where you are, and depending on the vaccine to some extent, is somewhere around in the ballpark of 10 per million or 1 in 100,000 to maybe twice that. And so it's definitely first was seen in young adults before vaccines were given in adolescents. So young adult males, sort of 16 to 30, and then it can happen at any age and in any gender, but it's on that sort of excuse me, order of magnitude. What's also known is that if you have COVID-19 infection, that you can get myocarditis as a complication. And the myocarditis is a complication that happens after COVID-19 infection, can be severe. Data that has come from a variety of sources, but especially from the US and from Israel, has shown that the likelihood of getting myocarditis after COVID is at least 5 times, maybe 10 times more likely after having a case of myocarditis. Now, of course, not everybody gets myocarditis. It gets COVID, but if you have COVID, you're much more likely to get it than if you've been vaccinated, and it's more likely to be severe. The good news about the myocarditis that's occurred is that so far it seems that the cases are mild and not leaving lingering effects, but we simply don't know now what that's going to look like in the sort of medium term. The cases that occur soon after vaccination, typically within 5 to 7 days. And so it's not like somebody's going to get myocarditis arising. It doesn't seem like it, that it's going to rise weeks or months after they've been vaccinated. It'll rise quite early. But the period of time that we're worried about it will be uh, to see how whether it can happen after vaccine is quite soon after the vaccine, but time will tell about lingering effects, but it doesn't look like that's a big issue at this time. So the clinical trials in children in the United States, the FDA asked the companies Pfizer and Moderna to increase their sample size of children that they're looking at for these bridging studies. But the numbers are still relatively small, around 4,000 to 5,000 per age group that's being looked at as far as I understand. And so if you're going to study 4 to 5,000, 4 or 5,000, then you're simply not going to have studied enough children to have any sense of what the likelihood of myocarditis is if it's more rare than that. But in fairness, even if you studied 30,000 people like they did in the, or 35,000 in the large adult trials, you may not get enough of a signal to know. It won't be until vaccines get used on a sort of large scale basis that we'll get more greater understanding and a more precise sense of how likely or unlikely these events are going to be. Two more things. It's a long answer, I know, but I'll just offer two more things. The first is that the dose of vaccine that's being given to younger children is lower than the dose given to older children and adults. And so, for example, the Pfizer vaccine, the dose that's being used for children under 12 is 1/3 of the dose being used at older ages. And so that may be important when it comes to adverse events, because the other thing that's been seen, and there's data from Ontario on this and also from the United States, is that it seems that the myocarditis is probably going to be more common after the Moderna vaccine, which is a higher dose of the mRNA now than the Pfizer vaccine. Now, we can't compare those doses exactly because they're proprietary substances, but the amount of mRNA measured in micrograms in the Moderna vaccine is 100 compared to 30 in the Pfizer vaccine. And while that higher dose in the Moderna may be associated with a longer benefit of the vaccine if you're an older Canadian, when it comes to the myocarditis in younger Canadians, it may be that you're more likely to have that happen. So there's more to come on that. But in Ontario, for example, they've made a recommendation that they're preferentially providing the Pfizer vaccine to adolescents who are being vaccinated. So that lower dose again in younger children may have a benefit. So we can't just assume we're going to have the same kind of problem. That's a lot of information, but I hope that helped out people's questions.
Thank you. Someone else has asked, how serious a concern is long COVID in kids, and what are we seeing in Canada?
I can tackle that one. So it seems to be more rare than what we're seeing in adults. In fact, interestingly, and you probably saw this paper out of Israel, where they said that approximately 10% of children and teenagers have some symptoms of long COVID. Mainly parents were reporting attention problems or lack of sleep or problems with behaviors. However, in that paper, what wasn't done is to compare that group of children who had COVID to a group of children who didn't have COVID, because, put a couple of children in a room locked with a computer and see what happens to them down the road. And as Dr. Vaillancourt said, it has, virtual teaching has impact on our children's behaviors. So the same was done out of the CDC and in Switzerland. And then what's interesting there is that you see that 12 weeks down the road, approximately 4% of children who had COVID still had some symptoms of behavior problems or tiredness or whatever, but it was 2 to 3% in the control group, showing you that really, long COVID does not seem to be such a big problem in children, which is reassuring again. I know that in a couple of provinces, long COVID clinics have been put together by various pediatric groups, and they're not overwhelmed by consultations either. So yes, it might happen once in a while, but it seems much less frequent than in your adult population, where it seems to be more in the 25 to 30% of COVID cases that end up with long COVID. Thanks.
I'm going to see if we can sneak 2 more questions in here before we conclude. Someone has asked, would you recommend that vaccines for those eligible be a requirement for participation in youth sports and other extracurriculars? Whoever wants to take that, please go ahead.
Well, I know we want to be brief. I think that, it depends on age, it depends on setting, it depends on what you're doing. There's a lot of vaccine requirements for adults and for that are in place right now. I think that, the age of children who are participating in youth sports, goes down below the age of 12. And so certainly we can't say anything about that now. Will it be a reasonable thing to mandate vaccines for younger children, especially at a time when we'll be implementing vaccines and still learning about the vaccines? Or should we particularly mandate the vaccines for those around the children to begin with? The short answer to the question, I'm not sure that a vaccine mandate for children participating in youth sport at this time is the answer. And I think that mandates are more relevant in other settings to begin with. I can see it over time and depending on what we come to understand about the vaccines, but it's not the answer on its own. There are other considerations as well.
And that's exactly the answer I was going to provide. So we have good reliability on it.
Good to have a second opinion. Now I will ask one last question. Someone wants to know, is a negative test after a 7-day isolation enough evidence to allow a child back into school? They're asking, like, what do we know about what's gained on day 8, 9, 10 if we've had a negative test on day 7, and thinking about the balance on the stress to parents?
So that's an excellent question. And in fact, what we're seeing, and it's not just in school, but also in all those quarantine settings that we've mandated, is that if your PCR is negative on day 7, it's really unlikely that you're going to have anything creep up after that. You might miss one here and there, but in terms of risk to the society, I think that we could go back to school on day 7. In fact, Quebec is now sending children back to school on day 8 if their test on day 7 is negative after an isolation period. And we've been doing that in healthcare since the beginning because we didn't have enough healthcare workers. So we have, I think, enough proofs to show that if on day 7 you're negative, you should be able to go back to whatever you were doing before. Thank you.
I think we can sneak one bonus question in. Someone asked, many adults who are vaccine hesitant, I think here they're referring to parents on behalf of their kids, talk about the sort of trade-off, the cost benefit, given the fact that kids do pretty well with this virus, and the idea that they might not want to get their kids younger than 12 vaccinated. Would any of you have a response to that line of reasoning or thinking?
Yeah, I think hard to give a very quick answer to it. It's an important consideration for sure. And it's more risk benefit than cost benefit, is what is the benefit to the child? The UK and their decision to offer vaccines to children right now had a combination of their National Advisory Medical and Health Science Advisory Committee say that the benefit was marginal medically to look at giving the vaccine, but there are other considerations. The chief public health officers in the UK came together and said that the other benefits of vaccination, in addition to the direct benefit to children, the other benefits of vaccination in terms of trying to help keep the schools open, keep growth and development going, are also part of the consideration. And so I think that the consideration here has to be not just purely the medical risks, but the other benefits of the vaccine. And the second thing, very briefly to say, is because there's been a lot out there recently about, oh, well, it's not as bad as the flu. In fact, our data accumulating that COVID, although it's uncommon to cause severe disease, is as bad as the flu or worse. There's data from the CDC in the US showing that the death rate in children, low though it is higher than any flu year since in the last 7 years, and quite a bit higher on an annualized basis. And in Alberta here, we just looked at this last week. And if you look at kids who have ended up in an intensive care unit with influenza versus COVID, slightly higher number of children have ended up in an intensive care unit on an annualized basis with COVID than with influenza for the last 5 years. And so, although those risks are lower than in adults for sure, the risk in children is lower, but it's not nothing. And so that's already a much longer than I thought short answer.
Okay, if anyone else wants to chime in there, please go ahead before I do a little wrap up song and dance. Looks like we're sorted. So I'd like to thank our panelists and our audience on behalf of the Royal Society of Canada and the COVID-19 Immunity Task Force. If you want any additional resources or to see this presentation after the fact, please visit the RSC's website. And you can also join the conversation on Twitter by following @RSC The Academies. And if you have additional questions after the fact, you can send them to events@rsc-src.ca. And there it is up on the screen for you. And I think we're ready to call that a wrap. Thanks very much for joining us. This was really informative.